Just want to thank you for the privilege of being here, and just want to thank all of my gracious hosts. It has truly been a privilege to experience such warm Egyptian hospitality, so thank you. First, my lecture style, as I lecture at Stanford and all these courses, is very Socratic in nature. And what that means is I really want to initiate discussion. So I will not stay behind the podium. I will come up to you and I'll say, what do you think? And what do you think? And I will come and I want this to be very engaging. This is a Friday morning holiday. I don't want any of you asleep. I want all of this to be very engaging in our discussion. And I have much to learn from all of you, especially many of the esteemed ocuoplastic colleagues that I have here. I have much to learn from you. So I really encourage that discussion. So first of all, I'd like to know who my audience is. So how many of you are medical students or residents in training? Any residents in training? I see we have a lot of residents. Okay, wonderful. And how many of you are oculoplastic surgeons? And there are a great number of you as well. And just general ophthalmologists or other specialties within ophthalmology? I see we have. So I will try to attempt to speak to all audiences today. I can be a master of none, but at least I can attempt to start. So without further ado, let us get started here. So my talk is broken up into 6 parts. Initially, I would like to go through the basics of CT scanning and MRI. And for our medical students and residents, I find that even most ophthalmologists, when I lecture in San Francisco or at the university, most of them don't even know how CT works. You just order it. Or MRI, the same principle. None of us understand how these machines work. And so I like to delve deeper into the basics. I'll be brief. Yet I think it's very important that we have a fundamental understanding of how CT works, how MRI works, in order to leverage that technology. I do want to say that if you would like me to stop speaking, I know we have an esteemed speaker, please let me know, so I give you ample time to speak. So I will go through the basics of CT MRI. How do you read MRI? How do you read CT scans? And we'll go through case after case after case. I'm an orbital surgeon. I get sent the most complex cases from all over San Francisco, Northern California, and these are very difficult cases, and oftentimes the clues are in the CT scan and the MRI. So I would like to go through that today. So we'll go through case examples, we'll go through differential diagnosis. I have a very different way of thinking about orbital tumors and surgery, so I'll share that with you. And many of the oculoplastic surgeons here can criticize me and say, oh, that's new nonsense. We stick to the traditional ways which work much better for us. So please, I welcome that discussion. So the first is CT and MRI are really complementary. They're not mutually exclusive. In the United States, we have this problem that a lot of insurance directors and medical directors of these companies say, well, you can only get one or the other. The MRI is too expensive, so we only want you to get a CT scan. And so the fact is that the information derived from both are mutually complementary. So let's just distinguish a few of these characteristics. First, CT really helps you to take a look at the bone. If you have retinoblastoma, meningiomas, you want to look at the contrast between fat and bone, air and bone, soft tissue, etc. It's very useful. It is a very fast scan. So if a patient has anxiety or whatnot, it's very rapid. And the fact is, I don't know about in Egypt, but in the United States, it's at much lower cost. And so it is the preferred scanning modality in the United States as a first scan. MRI is very useful for soft tissue contrast. It's better when you're looking at the globe, the optic nerve, any intracranial disease. Its contrast is not as nephrotoxic. So if you have a patient with renal disease, it is very useful. And finally, there is no radiation with MR. So how does a CT scan work? So this is basically, there are some protocols that I ask for. CT scan is very useful for traumas, fracture, foreign bodies, when you're looking at the bone, and if you want to see, is the bone invaded? If you have a malignant tumor, is the bone eaten away? These are all things you want to look at very carefully. So these are the protocols that I ask for. You have to be very specific for the radiologist and the scan in the United States, because oftentimes they will mess this up. First is, how thin of a slice you can get. And that is often dependent on how strong the CT scanner or the MRI is. So the CT scanner comes in a 4-row scanner, a 16-row scanner. The standard in the United States now is a 64-row scanner. And that should allow you to give you 1 millimeter cuts. And I ask for 1 millimeter cuts that are direct, coronal, and axial, so I get a full picture. So when you do a reconstruction algorithm, so even if they're scanned this way and this way, you can reconstruct it in very high definition. Because oftentimes if you have, say, a low row scanner, such as a 4 or a 16, and you do thick cuts, such as 3 millimeters, what if the tumor that you're looking at is 1 millimeter? You will miss that tumor if it cuts in between that. That's known as bread loafing. So you want to look with contrast if you have masses or inflammation. If you think you will have inflammation or a big tumor, contrast is very useful for that. And you also want to check for renal function, especially in your diabetic patients. And if they're on dialysis, it's not a problem. It's okay. So CT scan, the mathematical principles were developed in the early 20th century, and it showed that you could bisect the image as opposed to having it compressed all on each other. And you can see here, there's the classic X-ray where the whole image is compressed on top of each other. And this is known as a Caldwell projection, where you have all the images on top of each other, just put together. And this is in contradistinction here to a CT scan where you get a single slice through that image, which is much more useful. This improves the resolution and the contrast of what you're trying to look at. Basically, what a CT scanner is doing is at multiple angles, it's taking multiple X-rays. It's not rocket science. It's basically different angles cutting through the body, creating different X-rays at different points. That's all that it is. So you can see, you get the reconstruction, you get all the image data that's then done through the computer, and you get what's known as tomographic reconstruction. Now we will go through the calculus of this right now. That was a joke. Please, no one laugh too much right now. But basically, with my residents and all this, I quiz them even on the fine details of all the algebraic equations, etc. for fun. But we'll spare that for you today. So the first question is, when you look at a CT scan, is it a bony window or a soft tissue window? So let me go around right now. And everyone, this is where everyone gets nervous. So I don't want to, in the US, I call on my residents. I say, what is the answer here? And they get all nervous and scared. But I will be polite here. I want to be very culturally appropriate. And so, what do you think of this? Is this a bony window or is this a soft tissue window? Excellent. And then how about there? For the medical students, how do you tell the difference? You have to look at the marrow of the bone. You're absolutely right. Because this gives you an indication of what you're trying to focus on. And the same goes for this. This is as opposed to a bony window, a soft tissue window. So you're absolutely right about that. Next slide. Next, I would like to go through the anatomy. So most of the residents know this. Some of the medical students do not know this. Do we have a pointer by chance? A pointer? No? Anybody have a... Well, in any case, let's ask some of the residents. Can you tell me what number 5 is? Number 5. Excellent, the eye, that is right. Okay, so we're all ophthalmologists. I would hope that you know the answer to that. Okay, number 6. What is number 6? Okay, good. So the next few minutes, for those of you who are oculoplastic surgeons, please spare me your patience. But I want to make sure everyone understands the anatomy, because by the end of today's lecture, all of you should read a CT scan, MRI without any issues and understand every fundamental detail of them. So you can see here, what is number 3? Good. And then how about number 2? How about 12? Which sinus is this? So 12 is anterior to this sinus, which is 13. What is 13? Sphenoid sinus. Excellent. How about number 12? Excellent. Ethmoid sphenous, etc. How about these structures? Number 10. Inferior turbinate. Excellent. Number 9. Maxillary sinus. Number 8. Excellent. How about number 3? Superior rectus. Excellent. Number 4. Excellent. So these are just some of the basics. I'm not going to go through the rest of these. I mean, you know what number 6 is, lateral, medial, etc. So excellent. Let's delve into this further. So nasal septum. How about number 1? You can see right here. Exactly. The lacrimal system that you must be aware of. And how about these structures? I think this is where it gets a little bit tricky. So I want to delve into a little bit the more difficult things. It is very apparent that you understand all the fundamentals of the basic of anatomy. So I'm not going to spend too much time on that. I have to compress this lecture into 45 minutes. So how do you distinguish? I'm going to go through some of the more difficult points. How do you distinguish the optic canal versus the superior orbital fissure? Can anyone tell me? So number 7 versus number 12. Okay, I think what you're saying is, and we'll go through this in a little bit, is this diagram right here. And so if you see the anterior clinoid process right there, which divides this structure, and at the base of that you see the optic strut. And so you can see here, it's really an issue of directionality. The SO, the superior orbital fissure, will always come out in contradistinction to the optic canal, which goes medially. And so let me see if I have a better picture of this. Can you see this, where this direction, where it comes medial, is the optic canal? And what runs in the optic canal? Excellent. As opposed to the superior orbital fissure, which goes out this way, and you can see that better here in these slides. So I hope that's very clear. Look at the directionality. What is the angle at which it's going to? So what is the diagnosis here? Thyroid eye disease. And which muscles are affected first? Inferior. And then? And then? And for the residents, how you remember this for the rest of your life? How will you remember that order? I am still. No. I am Scott Lee. So you'll never forget that for the rest of your life. I am Scott Lee. Not all of you are Scott Lee, but still, my point is that this is the way to remember this. Now, how do you differentiate in thyroid disease the difference between this versus, say, pseudotumor? Everyone says that's the theoretical answer. But if you get a CT scan and you're looking at the tendons, are you going to be able to tell the difference? Maybe sometimes, maybe yes. But sometimes if you have early disease, is the tendon affected? Is the tendon not affected? It's very difficult to tell. I would say the easiest way when you look at a scan is to look at the fat. And so this is the difference here. This is called fat stranding. You can see that it's very dirty right here. What's a good analogy? It looks like there's a lot of food right there in between the orbital space. You know, it's mucky, it's dirty, it's very tasty. But anyway, no one gets that analogy. But if you can see right here, it's very dirty as opposed to this, which is very clean. Do you see how there's no fat stranding here? And so often when you get a CT scan, the neuroradiologist will say, oh, this is non-specific orbital inflammation. This is pseudotumor. When in fact, it's thyroid eye disease. And the one rule that I've learned is never trust the radiologists. And I don't know how they are here, but in the US, they don't know what they're doing 90% of the time. So read your own scans. So I want all of you to read your own scans, and by the end of today, you will know how to read. I'm trying to compress 5 years of radiology and 2 years of neuroradiology into 1 hour. But all of you are very bright, and so you will learn this in 1 hour, okay? So you can see here that there's that differentiation. What about here? What's the diagnosis here? Anybody have any thoughts? Again. So I just want to... Looks like, exactly, the ethmoid sinus is very much affected here. But let's just return to the fundamental basics first for our residents and medical students. Can you tell me if this is an axial scan, sagittal, or coronal? Good. What if it were axial is like this, if you cut my head this way? Coronal is what? Good. And sagittal is? Okay, excellent. I feel like I can go much faster because all of you know all of this already, which is great. So MRI. Does anyone know how MRI really works? Anyone? So let me go through that. Even most ophthalmologists, oculoplastic surgeons, all we do is order the scan, and we don't have a fundamental understanding of how it works and why it works. When do you get T1 versus T2? When do you get a flare sequence? When do you get this scan, that scan? Does anyone know? And so I want to go through that right now. So the first thing I want you to do is this is how the protons are in our body. And let me see here. Okay, well, I'm going to show you that in a second. But MRI is very good for vascular malformations. If you have any venous, lymphatic, hemangiomas, malformations, etc., it's very useful. It's very useful in tumors, inflammatory disease. So the higher the Tesla, the more magnet strength you have. And so I prefer to get as high of a Tesla as you can get. And in this case, I get, at Stanford and all the other places, we have a 3 Tesla. I don't know about here, but 0.9, you miss a lot of details. Most MRI machines are 0.0 Tesla for a long time. And then they moved to 1.5, which I think is sufficient for a lot of the work that we do. T1, FAT-SAT T2, post-gadolinium FAT-SAT T1. We're going to go through all that. These are just the basic protocol pearls that I ask for. Axial and coronal planes, and ideally you want to get 1.5 to 2 millimeter cuts if you can with your machine, but even 3 millimeter cuts, you have to live with. And we want a small field of view and a high-res matrix. And what you ask for is you want the orbital roof to the soft palate for your axial scans, and the coronals, you want the orbital rim all the way to the colliculi. And sometimes if you don't tell this to the radiologist, they forget, and they will stop the scan in the middle or whatnot, even if you have a protocol in place. So it is so important to let people know exactly what you want on your scan. So the first thing I want to do is show you how this works. So this is a radiofrequency pulse, and so the protons are then zapped. And then the protons are rotated 90 degrees. So in order for you to remember this, we're going to do this in live time. So I want you to put your hand on the person to your right. Okay, now turn the person. Turn them. This way. No, you have to rotate 90 degrees. No one is listening to me. Put your hand on the person on the right. Now turn the person. Turn. Okay. So, and then slowly rotate back. Okay? And that is what the proton is being done. It's rotated. I'm going to make you more participatory in a few minutes. There needs to be more pushing and whatnot. Okay? So you rotated 90 degrees. Maybe I can have you as an example here, since everyone is somewhat shy today. So I'm going to spin him. So the proton beam comes, zoom, the magnet comes, and he gets turned right away. And as he turns back, the speed at which the proton turns back is the image that is released and being captured. So I'm going to go through this with T1, T2, all that. Thank you so much. What is your name? Okay. I'm going to do this for 5 times in a row to explain T1, T2, FAT-SAT, all that in a second here. So when the proton relaxes, there is absorbed energy released, and this is a radiofrequency wave and a time-dependent decay. And it's that timing that gives you the image that you're looking at. So when it is spatially recorded, you get differential images. So what is the difference between T1 and T2? So T1 is known as spin lattice. It is increasing return of the dipole moment back in line with the magnetic field. T2 relaxation is known as spin-spin, and it's the ability of the relaxing protons to induce spin in surrounding unexcited molecules. Now, this doesn't make any sense until I show this to you. So let me show this to you right now. So T1, let me do this again. So everyone, put your hand on the person to your right again. Okay, and spin that. Spin, spin. No one is spinning. This must be a cultural thing. In the United States, I have everyone spinning at the same time. Okay, and you turn back now, slowly. Okay, you need to come up again. No one is doing this. All right. So T1. Actually, we need another volunteer. So we have one of the medical students in the back come up for this. So these are both hydrogen molecules. Okay, so you'll stand right here. So T1 is known as spin lattice. So I turn, the magnet turns, you turn too. Okay? T1 is, I'm returning back, and you see as he turns, he has a certain spin and a grace to him as he turns. And that is emitting that energy which is then captured. Now, what is T2 is, as he's turning back, he's violently shaking the other molecule. Shake him. No, like this. That is T2. So what you're measuring in T2 is how his energy is affecting this molecule. Does that make sense? So it's not the incipient aspect of it, it's the secondary. So T1 is what energy is given off when he is returned to his original state. T2 is how hard he is shaking him as he turns back. What is your name? Mohan. Thank you so much. I appreciate it. Okay, I'll keep bringing you up. I'm sorry to disturb your learning. So does everyone understand the difference now with T1 and T2 on a molecular standpoint of how that is working? Excellent. So T1 and T2 relaxation times occur simultaneously and give different characteristics of the tissues being imaged. The protons within high molecular weight complexes, such as fat and protein, dissipate energy much faster than, say, water or low molecular weight. And this is why you get very bright images. So you can see here in the fat, because it returns so fast, it dissipates the energy very fast. And that is why you get these images right here. The next one is large molecular weight complexes such as fat and muscle are much better at inducing spin in other structures. And therefore they lose their signal very quickly versus water. So you can see here all these lesions in T2 are giving up their energy very quickly, and therefore it's dark. So you can tell the difference between T1 and T2 depending on that. And I'll go through example after example to show you this so you understand this. So tightly organized structures such as muscles and the ligaments, such as very tightly woven myosin and actin, don't really do much in either. In T1, they remain dark because it's very difficult to dissipate the energy. And in T2, they also stay dark because the fluid in that tightly wound structure is very little. So in both of those cases, they remain relatively dark. And you can see here the lateral rectus or the medial rectus right there. It remains dark in both situations. So when we describe a scan, we always refer to the muscle, whether it's hyper, hypo, or iso, in terms of respect to the muscle, in terms of its density on the scan. Does that make sense? The density, the iso density, the hyperdensity, or the hypodensity.
This is for CT density, right?
No, we're talking about MRI right now. Yeah, MRI, how white or how dark it is on the scan.
Technology is intense or dense?
Intensity. Not density. Yeah. So I will go through that in a second here. So what are the parameters that you should ask for? There's several things you should ask for. So one is the repetition time, which is the interval between the radiofrequency pulses. How often are you shooting your magnet? Second is the flip angle, the angular displacement of the dipole with respect to the radiofrequency pulse. So what angle is it being measured at after which the magnetic pulse is instituted? And third is the equitime between the pulse and coil recovery. How long does it take between those two to recover? These three variables combined together give you T1 versus T2. So T1 will have a low repetition time and a low echo time. T2 will have a high TR, or repetition time, and a high TE. So it's just reversed. And when you use the abbreviation, time echo, or echo time. T1 is best for anatomical detail. When you want to look at the anatomy of something really well, the fat, the protein, the bone marrow are relatively bright. And in water, edema, aqueous fluid, all of that are relatively dark. In T2, the fluid is very bright. If you have edema or swelling, you're looking at the aqueous or the vitreous. Those things are very bright. And if you're ever confused, you should typically look at that, except for the things I will show you in a few minutes so that you're not confused. It's good for pathology and inducing surrounding edema and inflammation. So what is fat saturation? We always order fat sat, but we never know what it is. When do you do fat saturation? So the hydrogen nuclei of fat and water resonate at very different frequencies, but they're very close to each other. So fat and water are often very much confused in a T1 scan. So you're doing selective saturation of just those fat protons at that frequency. So you do this prior to acquiring your data. You make it quiet out, and it results in a negligible signal of bright fat, and you get just the water here. And you can see here that that's what you're doing in, say, the T2. And so you can see here in this example, can anyone tell me right here, this is with all of it in place. You can see that it has not been selected out for. And you can see, is the fat very bright or dark here? Bright. And then when you start to suppress it, you can see all the structures there. What is this structure right here? Anyone? Superior ophthalmic vein. Excellent. And then if you look right here at the choroid, the choroidal structures, you can see the choroid is the most vascular structure in the whole body. And you can see because of that, it still lights up. What is flare? So flare sequence, which we often get, but no one understands what it is fluid attenuated inversion recovery. And what it is a sequence to take the null signal from fluids. For example, we use this typically to suppress the CSF. We make the CSF go away as a signal to be very quiet when we're looking for periventricular lesions in MS. So you have a patient with optic neuritis. You want to order a certain scan to look at the periventricular lesions to see if they have MS. Make sure you order a flare sequence. Is that very clear? Because you want to suppress the fluid in terms of, because the fluid that's there versus that within the brain and the periventricular lesions will be very similar. And you will miss that. And you'll be confused when you order the MRI. So just make sure that you order the flare sequence in those circumstances. So this patient right here got scanned for the purposes of this lecture. And you can see here that even apparently a normal scan does not rule out any psychiatric pathology. So anyway, no one laughs at my jokes these days in the US anyway, but you can see this is a scan that I took of my own brain. And you can see here that this is apparently a very normal scan. So this is the flare axial T2 that I discussed just now. This is a flare sequence. You can see that all the fluid here is really quiet because we're looking for the periventricular lesions right alongside the ventricles to see if there are any lesions in MS. As opposed to, say, T2. And you can see T2, you can see that the fluid here lights up. So this is a very classical T2 scan, flip angle of 90 degrees. And so I want you to be able to distinguish when you get an axial versus that of a T2, because they can be very similar. But you notice that difference.
So the parenchyma here is of Korean origin? Or?
You were right, yeah. I don't know how you can tell just by looking at the scan, but that's very impressive. Very impressive, yes. We have some very smart ophthalmologists in the audience here today. So what is gadolinium? So gadolinium, most MRI contrast agents are gadolinium based. They shorten the T1 relaxation time. They're much safer than CT contrast in renal patients. And what they really do is they break through the blood-brain barrier if there is some pathology going on. And so you can see here, this is one of the things I want you to be able to distinguish, is T2 flare versus T1 post-gadolinium. And so you can see here, they seem apparently normal. If you look at this scan, for T2, you've typically looked at the vitreous to say, oh, that's T1 or T2, right? But you cannot do that in this case, because this is a T2 flare sequence where the fluid is quieted out. And so in this case, you can see here that the fluid is quiet, even that fluid is quiet. This is a T2 flare sequence. This, in contrast to T1 post-gadolinium, again, it's dark in the middle. So you can't just say T2, T1, T1, or T2, T2, just based on the vitreous, as you typically have been doing. If you look carefully here, what do you see? T1 post-gadolinium, you can see all the structures are filled with a contrast. And if you are ever in doubt, you can look at the dural sinus. You can see right there how it lights up very brightly. So did the patient get contrast or not? Typically what you do is you look up here and it says with contrast or without, because you don't know if they're doing. But all you have to do to impress everyone around you is say, aha, look at the dural sinus. Look at all the structures that are filled with the white here. And so therefore there is gadolinium present here. And this you can see it's quiet throughout. And this is the flare sequence or the fluid. You can see that it's slightly different because this is a gray color. Do you see how this is gray and this is pitch dark, black? And that is how you'll distinguish those two. So this is a T1 axial scan, and you can see this is the classic picture where the vitreous is dark and it is white here. And then when you add the gadolinium, it starts to light up. Again, the dural sinus, you can see here in the vessels, the sinus, again, no contrast and with contrast. Is that clear for everyone? Do you see that? The difference between with contrast and without. And this is the same thing. With contrast, no contrast, this brain tumor looks normal. You can't tell. But when you instill the contrast, you're breaking down the blood-brain barrier. And when you break down the blood-brain barrier, you can see, aha, there's a big lesion right there. There's a big tumor in the brain right there because of the contrast. So if there's ever any question of a tumor or inflammation or breakdown of the blood-brain barrier, you want to make sure that you go ahead and get contrast. So there are many types of gadolinium. These are all the various types that we have. I don't know what they have available here in Egypt. Which one? I'm not sure. Yeah. So what is Tesla? Can anyone tell me what Tesla is? I explained it earlier. Anyone?
Yeah, the electric cars.
You're absolutely right. So Tesla is the electric car that is... Do they have Tesla in Egypt yet or no?
It's coming.
It's coming. Okay, it's coming. In the United States, it's a big headache. It's a very expensive car, and then you have to always plug it in. And it's hard to find the plug. It takes forever to charge. So I recommend not getting the Tesla. But anyway, those of you have too much money, you can buy a Tesla if you want. But this is the equation here, which determines the strength of the magnet. I will spare you the details of that, although I know some of you very much would like to go through all the algorithms to get this equation. And again, Tesla is basically how strong of a magnet you have, and it's the magnetic field strength. You can have the lower, older machines are 0.9 Tesla up to 1.5 or 3. It really does behoove you to find out how strong the magnet is at your institution, and to find out how strong of a magnet it is. So let's just go through the differential diagnosis of orbital lesions. And we'll go through scan after scan after scan. And I want you to get very good at making the diagnoses, etc. So this is the traditional way, where you have congenital lesions, you have vascular lesions, inflammatory, infectious, tumors, and trauma miscellaneous lesions, etc. And this is the differential that you've been taught for all the years here. It's very complex. Some of you will forget this as you go through this, especially the residents. My residents at Stanford have a very hard time remembering all of this. And so this can be very difficult. So there's a paper that was published about 10 years ago about maybe we should rethink orbital imaging. We should rethink how we do this. And so they, in this large group, took all their orbital tumors over a 20-year period. And then they looked at the imaging characteristics of that. And this is what they came up with. location, content, the soft tissue characteristics, the bone characteristics, and their associated features. And so I'm going to summarize all of this. This is a very complicated slide. I want to summarize all this so it becomes very easy for you. And we're going to go around the room and we're going to quiz you on various scans. So I call this mnemonic lead bombs. Lead bombs. LEDBOMBS. Lead bombs. And what that is a very systematic approach to approach any scan. So I want you to go through each one, and we'll go through scan after scan and practice this today. So the first is location. Just by virtue of the location, you can rule out 90% of the tumors that you're looking for. So I'm going to go through and we're going to practice the location one. Then the type of enhancement. Is the enhancement with contrast, is it homogeneous? Is it cystic? Is it heterogeneous? What type of contrast is going on? And that will help decide maybe it's this tumor or that tumor. So the third is the density. The intensity and density. You had questioned this earlier, but is it iso-intense, hyper-intense, or hypo? And that is something that you do with respect to the muscle. The fourth is the shape, and is it round, or is it oval? And we'll go through that. Or is it, different shapes lend to different types of tumors. And the fifth one is the border with the margin. Is it well circumscribed? Is it well encapsulated? Or is it diffuse? Is there indenting or molding? Is the tumor pushed in or not? These are all things I want you to go through and ask. And finally, if you look at the bone, is there a remodeling? Is the bone being eaten away? Particularly in malignant tumors, the bone is being eaten away, and that's something that you have to think about. And finally, you have to look at the nerves, especially if there's perineural spread, because if there's perineural spread, again, what are you worried about? Malignancy. So what they found in their large study of thousands of orbital tumors is that 50% of these were benign. And typically the benign ones were well circumscribed, they were oval in shape, and iso-intense on T2 imaging. The malignant tumors comprised another 25%. They were irregular in shape, there was a lot of molding, they were diffuse, there was bone erosion, and there was perineural involvement. And those are the characteristics there. And last, 25% is the orbital fat stranding. There is, as I showed you earlier, some inflammation, etc., that results in orbital fat stranding where you have a very mucky or dirty fat. So let's go through the first one, which is the location. So if you look through the location, the first question is it intraocular? Is it transscleral? Is it within the optic nerve versus the nerve sheath complex? Is it intraconal versus extraconal? And is it both lacrimal glands, or is it just one lacrimal gland? Is it isolated? And these are all questions you need to ask. And is it intracranial? Is there any direct extension versus a secondary process? And so this slide very conveniently summarizes a lot of this. For example, if you have a maxillary sinus tumor that's pushing the eye upward, is it going to be one of these other diseases? Is it going to be a frontal sinus mucocele? No. The anatomy drives the direction in which what lesion you're looking at. So if you look at all of these tumors and how, say you have axial proptosis, then you have to start thinking, well, this is my differential. You don't have to worry about a maxillary sinus tumor or frontal sinus mucocele, etc. So depending on where the lesion is and which direction it's pushing, or where the involved lesion is, you will start to narrow your differential diagnosis very quickly. Does this slide make sense? So again, this is more of a traditional technique, where you look at an orbital mass. Is it pediatric? Is it adult? These are the pediatric tumors you can have, capillary hemangiomas, lymphangiomas, etc. Again, this is more of a traditional approach, but let's continue. Again, traditional approach, meningioma, gliomas, neuritis. These are all things that you look for in these lesions. Again, a much more traditional approach, I'll go back to this slide in case any of you needed to take a photograph of this. And this is just more of the traditional approach of all the various lesions that you can look for and you should keep in your mind. So I want to go through each of the systematic approaches right now. And I will go through the audience and we will ask you just a word on orbital masses. They all look very similar. You know, I've been doing this now for 15 years. And in 15 years, so often, I think it's one thing. I go into the orbit, I pull out the tumor, something else. This happens all the time. So just because you have a differential diagnosis and it's very narrow and you say, it is this, you are often wrong. So approach every surgery with humility, that you may not know the right answer even before you go in. So the number one point is we are easily fooled. But often it can help you in terms of, for this lesion, I only should do a biopsy. I should not take the whole thing out. In another lesion, you should take the whole thing out because of what you think it is. And so we'll go through that right now because it will guide what kind of surgery you should do. So we'll go through what kind of slice. We'll go through the basics. CT MRI. Secondly, is this coronal, axial, or sagittal? We'll do this so that the medical students and the residents get very comfortable. Then we'll go through the lead bombs. Where is this located? Is it well encapsulated? Is it diffuse? Is there bone erosion? Blah, blah, blah. We'll go through all those questions right then and there. And so just want you to think of, these are all the various considerations that you could have in terms of bone remodeling and the lesions that occur with that. If it's cystic versus solid, these are some of the lesions that you can start to think of. So, I think a lot of you have very good knowledge and understanding. So I'm just going to go to the cases now. Again, in the child, these are some of the things that you want to think about. Bone remodeling, periosteum. What type of enhancement pattern? Is it patchy or is it relatively smooth? And these are the enhancement patterns of the contrast, etc. If there's solitary or multiple lesions, if you have one versus many lesions, it leads you to think of different types of lesions. So without further ado, this is what you've been waiting for. And please stop me if you need. Okay. No, thank you very much. But please, you stop me anytime. You run the show, okay? So if I'm getting boring, please stop me. Any of you, throw oranges or whatever. I will leave the stage, okay? So this patient, elderly gentleman, referred to me for ptosis. So, should I do levator resection on this patient? I always do a thorough exam, or I try to, and there's something there. Maybe we shouldn't do ptosis surgery. Referred by another ophthalmologist for ptosis, but you lift up the eyelid, and voila. What is that? Okay, so maybe we can have one of our lovely residents come up. Who would like to volunteer themselves? I'm not a scary person, unless I'm here in public. Anyone? Anyone? Whoever wants to. Go ahead. Yes. Mike, how are you? Good. So, we have one of our illustrious residents from the U.S. So, tell me, is this axial, coronal, or sagittal?
This looks like an axial.
Axial scan, etc. Excellent. Is it CT or MRI?
This looks like a CT.
Excellent. And what do you see?
So, the most striking thing to me, there's some lesion here.
Yeah.
Lateral side of the left eye.
And how would you characterize the lesion?
So, it is more dense than the eye itself. So, but not as dense as bone. And it is pressing on the eye. It is being indented by the eye as well.
So you think there's indentation of the eye? Okay.
Of the mass as well. It's kind of taking the shape around the eye.
Uh-huh.
But the eye itself still looks, let's see. I'm not sure.
That's excellent. Excellent, Michael. So what if I show you another scan here? Does this help you? So this is the bony window, right? This is the bony window of CT scan you can see here. Maybe I'll show you this slide. This is which cut? Coronal. So this is a coronal cut. And now what do you think? Is it well circumscribed?
No, it doesn't look like it.
It doesn't look well circumscribed now. This is why it's so important to read every single slice. Because in the last one, it looked like it was well circumscribed, right? And here, it doesn't look so well circumscribed. And the last one, he said, maybe it's indenting the globe. Is it indenting the globe here, or is it forming around it? It's forming around it. So this changes your differential diagnosis completely, does it not? Right? So this is, at first he was thinking, oh, this is pleomorphic adenoma, right? So that's what he was thinking, because if you look here, it looks somewhat well circumscribed. Maybe it's indenting the globe, it's superior temporal, etc. But then you look at this scan right here, what is your differential now? Yes. Excellent, excellent. So this changes your surgery completely, right? Because if this is a pleomorphic adenoma, what should you do? Totally excise, because you think about malignant transformation, right? But in this case, what are you going to do instead? Excellent. It was more inflammation.
It's very anterior. You can see it here, I guess.
Yeah, this. So you're thinking, the question you're trying to ask, why don't you just take a biopsy of the conjunctiva right there?
You're making the diagnosis, right? The silent patch probably, or just an easy anterior extension, right?
Yeah, so you're thinking of taking a biopsy right here. Sometimes that works and sometimes it doesn't. You know, I would say 50% of the time you send it off to pathology, insufficient sample or they couldn't tell, etc. But I think it depends. You do the least amount possible. I'm not taking off his bone. You know, I'm not taking off his bone for this.
Our pathologists are better, I guess.
Okay. Okay. So, excellent. Thank you so much. So, excellent. You can see here in other scans it looks different. So, you know, the benefit of this lesion is so often you would just go in and biopsy this. But I've also done things a little bit differently. In my training 15, 20 years ago, I did all external DCR, and that's all. And now all I do is endoscopic DCR because it's much easier, takes me 7 minutes to do, and the patients are a lot happier. Same with this. Our training for this was just take a sample, maybe a transconjunctival sample, and the patient is happy. But the superior temporal location was a very safe thing. So I went in, I dissected it all out as much as possible. There was a decreased lymphoma burden. The patient's ptosis resolved immediately, and they were so happy. So instead of waiting for weeks and months for the chemo and all this to set in and to treat this, and that's what the textbook tells you to do, I encourage you to find your own path in your own way. Because the textbooks are always often wrong. As the dean of my medical school said, 50% of what we teach you is wrong. We just don't know which half is wrong, right? So, again, same thing. This was a different approach I took. And so it's really up to you. Medicine is an art. All of you are artists and healers. And it's really up to you to decide what do you think is the best for the patient. So the textbook would be just take a little sample, send it off, or maybe take a transconjunctival biopsy, and you have the answer, and you wait for weeks and months, and hopefully the eyelid comes up again. No, we fixed his ptosis by just taking out the mass, and he was very happy.
But to refer the patient after taking the biopsy, if it is like malignancy or chemo and the radio, something like this?
Yeah. Then we work with our hematology oncologists, and they give systemic medication. And often I find that because if I can decrease the tumor burden, like there have been cases where I've had B-cell lymphoma wrapped around the superior oblique, and I dissect that to the superior oblique, and I take off the tumor, and it's a 2-hour surgery, and I think, why am I doing this? You know, the textbook tells me just to take a biopsy and then you're done and you treat. But those have been some of my most grateful patients. The double vision went away immediately, and they were so happy that we had removed their tumor. And they didn't even...
biopsy, or you can excise
Well, in theory, you're supposed to do the biopsy. But in that case, I took off the tumor because it was unclear. And when I took off the tumor, they were so grateful, and they did not need any systemic chemotherapy after that patient, that case.
What I do in this case, I do systemic work for the patient. If it is free, first I do incision for it. And I have an application supported in 2001, and it was the first application in the literature about just incision of primary lateral gland lymphoma without any post-op radiation.
Wonderful. So I follow in your footsteps. I did not read your publication, but I follow in your footsteps. So that is wonderful. What about this lesion? Do we have any more volunteers? Who would like to volunteer for this one? Anyone? Who would like to volunteer? Do we have any volunteers? This is a very quiet crowd.
So you have a shaggy mass that is hyperdense, intracorneal, and extending to the optic nerve and the superior division.
Yeah. Again, very similar. You clearly have a lot of experience with this. Again, fimbriated border. The word is fimbriated. You can see that the edge is very much, and so this is just to drive home the point to you over and over, to think about this. Look at the border, where is the location of the tumor, etc., and how are you going to approach this patient? So this is, again, the same as the last patient. What about this patient? This patient also presented to me for a little swelling, a little ptosis, and so what do you think is going on here? So first of all, where's the location? Yes, indenting the globe. Do you see that? Everyone see how the globe is pressed in? Do you see that? Okay. Any other thoughts?
There's I think a lateral and inferior inflammatory component as well, right?
Sorry?
There's a lateral and inferior inflammatory component. It doesn't. What you see there.
Yes, yes. Yeah. Excellent. So what is your leading diagnosis here? Pleomorphic. So how are you going to approach this?
What I do now is through lead just via lead transceptor. I'm working now in a very extensive study for more than 17 years. What I do, just excision of the mass via the lead transperostal approach without any bone division or period disruption. And it's working well.
Yeah. I completely agree. I try not to do surgery if possible, but if I do surgery, I try to do as least amount as possible, minimally invasive, and you try not to take the bone off. The only exception for this is thyroid. And so if I have to do a decompression, I was taught when I did decompression, I just shared this with you as a fellow ocular surgeon, is we would grind the bone down. And I would grind all the way down to dura, and then once I exposed the dura, I did it for many years like this. And I exposed the dura, okay, now I'm done. And it takes 3 hours. Everything I used to do, has changed completely. 90% of how I practice now is completely different than during my training or immediately after my training. And so now what do? Is I just take off the whole lateral wall. I just take off the whole lateral wall. And this was pioneered in Australia by the people in Melbourne, where they just take off. And everyone says, oh, what about cosmesis? What about, and they do great, and it's fully decompressed. And it takes me 20 minutes to do instead now, as opposed to 3 hours. So anyway, I digress, but let's continue. So this is the tumor, and you're absolutely right. This is a pleomorphic adenoma. If this is a pleomorphic adenoma, you want to excise it in its entirety. And the reason why you want to excise it in its entirety is you worry about what's known as malignant transformation. This is a benign tumor, but then if you cut it or leave parts of behind, in theory, it may turn into a malignant tumor. What about this tumor? This patient here. So first, where's the location? Superior. Good. And what is this sinus right here?
Frontal sinus.
Okay. And so you can see, is this a cystic lesion? Cystic, good. I'm giving you all the clues, but don't give all the answers. Let them have a chance to answer. The two of you.
It's very chronic as well. You can see size that's been there for years.
It's enlarged. Excellent. You can see what he's referring to is the molding of the bone, which is excellent. What else do you guys see here? Very large tumor. That's excellent. Yeah. And if you look at the intensity, the density here, is it pretty similar?
Soft tissue. It's soft tissue. It's different.
I sense to the clitoris, more or less.
Yeah. So this is a frontal mucocele. Excellent. Let's go through some more cases. This is classic for your ICO exam questions. I don't know if I should tell you this, but I write all the questions for the Orbit Ocuolplastic section for the ICO exam. So everything here will be on your exam, okay? So those of you who have not taken the exam, I hope you're still not asleep, because these are the questions that I put on the exam. So what about here? This is classic appearance. And you probably have seen this photo on your exam. So first of all, what do you see here? So the turbinates, are these the normal turbinates? No, they're enlarged. And what about the appearance of them? Have you heard of the term ground glass? I don't know what ground glass means. It's, I guess, an ancient American term where you grind glass, or this is how glass was made or something. But it just basically refers, if you hear the word ground glass on your exam, it's basically the heterogeneous appearance of the turbinates here.
Fibrous dysplasia. Fibrous dysplasia.
Excellent. So there are many of you here who have been doing this for a very long time. Excellent. But you can see here the heterogeneity of not just here, but also if you look temporally right here, you can see that same heterogeneity. Excellent. How about this tumor? Where is this located? Let's ask one of our residents here. Not you. Any other residents want to volunteer? So first of all, is it intraconal? Well, first of all, let's step back. Is this axial, coronal, or sagittal? Axial. And this one is? Good. And what type of scan? Okay. And where is the lesion right here? And it looks like what? It's a little gray. Yeah. Excellent. And is it displacing other structures? Okay, so it's probably relatively solid. So are you thinking this is lymphoma? No, right? Because typically lymphoma will mold around, has a fimbriated border, and now you've ruled out 50% of all the tumors you were looking at. Your differential is already much more narrow. Excellent, well done.
So do you have the listing of the localized orbital lesion? Do you have the...
Yeah, I showed it to you earlier. Yeah, you can have that slide if you want later. But
So can you revise for the sake of the residents? If you have a localized orbital mass, you may think of a few things.
yeah, so that was the slide 20 slides ago. I showed you for the intraconal one.
You were awake.
Yeah. Okay. So everything they've said is absolutely correct. You have a well-circumscribed lesion pushing that structure that way.
Can I tell you something about this case? The amount of contours is not proportional to the size of the lesion. This means that it is a compressible lesion. And I think it is one of the criteria of Fibrous here.
So I too thought this was a cavernous hemangioma. It's pretty classic in appearance. Small, round lesion. You know, I take out 10 of these, they're all cavernous hemangioma. It's the most common one, right? But
Sorry, just in 5 minutes, going to move to the next talk.
okay, yeah, then I'll speed up here. So you're absolutely right. That's what I thought. But again, I'm wrong 50% of the time. So this, you take it out, oh, it's not a cavernous hemangioma. This was a schwannoma, you know? And yet they present very similarly. You can see like this. So even if you have all the right idea, but at least you didn't take a small little biopsy. You know, we decided to take the whole thing out. And so I'm going to speed this up. So this is a lateral orbital tumor here. This is a dermoid cyst. You can see here, classic appearance of the cyst. This tumor right here, This is adenoid cystic carcinoma. You can see there's erosion of the bone. It's eating away at the bone. That's how you know it's a malignant tumor. You can see here, this was a case where what is this structure that's enlarged? Anyone? So what is the diagnosis if you see this patient? CC fistula. Classic in appearance, you can see the enlarged superior ophthalmic vein, CC fistula. And then this patient right here has a very interesting scan. You can see here, we don't have time to go through all the lead bombs here, but you could see that it wrapped around here, around the oblique muscle. And this was a B-cell lymphoma, which we removed completely, and the patient was very happy. This tumor, again, same thing, well circumscribed, displacing structures, etc. Classic in appearance, and you can see here at the apex right here, and this was a cavernous hemangioma, as you would expect. I typically go laterally. I take off the bone, I take off the lateral rectus, and I carefully dissect to the apex. That is how I do these cases.